For instance, patients with high fats and cholesterol,
Okay.
we worry that very high triglycerides can cause complications for the pancreas. So we tell the patient, let's manage your fats first before we begin the treatment.
Now, this is a very important question. So I've continued with Mounjaro and reached my goal. I've been very frugal. I did everything. I spent everything I had to get a few months' supply, and I reached my target weight. So is it possible for me to continue with the maintenance, as they call it, or the stabilization phase using Ozempic? Can I switch? Or is that just a luxury,
No. It's not a luxury at all. We actually have existing protocols on how to shift between the two.
Welcome to a new episode of the podcast. Our guest today is the always distinguished Dr. Bashuni. Welcome to the show, Doctor.
Hello, Sally, and hello to everyone listening and watching.
It's a pleasure. Today, we're going to talk about the new beast that's taking over, the one that's trending massively for weight loss, and that is the Mounjaro injection. Of course, Doctor, you're going to discuss it in detail, walk us through its pros and cons, and the difference between it and the whole family of diabetes medications that are being used for weight loss. So we'll start by talking about Mounjaro and comparing it to other similar classes of medication.
Right? Mounjaro is one of the new drugs that for a few years now has been creating a lot of buzz around the topic of weight loss for patients with obesity or who are overweight. It was originally a treatment for diabetes. Its active ingredient comes from a class of drugs we use to treat diabetes. It made a huge difference for the patients who used it, and the studies conducted on it for obesity have shown excellent results. So it received approval to be released as a standalone treatment for weight loss, even if the patient doesn't have diabetes. It achieves great results, leading to a very significant percentage of weight loss. Of course, there are precautions and conditions for its use. And let me just take a moment to seize this opportunity and tell everyone listening today, or anyone who has information about Mounjaro, whether before or after hearing this, do not get it on your own. It must be used under medical supervision because it's one of those medications that can cause some complications if not used with proper medical supervision. Also, some patients may not be aware of the safety profile, the contraindications, or the necessary precautions. So they could be harmed if they use it without proper medical oversight.
If they take it without a doctor's guidance, yes, exactly.
So if we talk today about anything regarding dosages, method of use, or duration of use, the goal of this video is to raise awareness. But no one should use this as a guide to get the medication on their own and take it. It must be used under medical supervision.
Perfect. Okay, so what's the difference between it and another name that was also leading the trend for a while, which is Ozempic? What's the difference between them and which one is more effective?
Right. Look, they're both good. They're from the same class of drugs, but the active ingredient is different. Mounjaro and Ozempic are like brothers, but one is cheaper than the other. Mounjaro is much more expensive than Ozempic, and Mounjaro is a little bit more effective than Ozempic. The contraindications are the same. The precautions for use are almost the same. The duration of use for both and the dose titration are nearly identical. We increase the dosage in a very similar, gradual way, with some difference in the concentration of each type, of course. But we take this into account with the patient when we're choosing the medication. Some patients can't afford to take Mounjaro because its price is very, very, very high. He's a regular guest of ours, yes. So its price is a bit high. Some people can't afford it. So when we tailor the best option for each patient, if we find that we're going to use medications, we take the price into account and we take into account the patient's experience. The patient's experience and whether they can afford both, so we can decide which one to proceed with. So both are good. Mounjaro is a bit more effective and much more expensive. Ozempic is very effective, but its price is much lower. We're not advertising for either of them. We're just saying both are good. We just wanted to clarify some of the differences between them.
Okay, a question. When you say effectiveness, do you mean both cause weight loss, but one is faster? Or does one cause weight loss only up to a point and then stop? What exactly is the difference in effectiveness you're talking about? What does it mean?
So roughly, most patients who take Mounjaro reach a 25% weight loss. With Ozempic, not everyone reaches 25%. Some do and some don't. The time frame is about the same if we're talking about the first 3 to 6 months. Our goal to consider the drug effective is for the patient to lose about 5 to 7%, or at least 5 to 7% in the first 3 to 6 months. And for those listening who might be alarmed, thinking, I'm paying a lot for this drug just to lose 5 to 7%, I tell them no. We're just stating the minimum expected loss at the start in the first 3 to 6 months. But in reality, we find that in the first 3 to 6 months, a patient can lose from 10 to 20% with either drug. For patients who take Mounjaro, most of them reach a 20 to 25% loss without much difficulty. With Ozempic, we find that not everyone achieves that.
Right? It varies from person to person and depends on how their body responds to the drug, so the response will vary.
That's true. Exactly. I mean, sometimes we give a patient Mounjaro and don't see a good response. So we switch them to Ozempic, changing the active ingredient, and vice versa. So that's a very valid point. Every patient has their own response, or their body has a specific way of responding.
Okay, so if we were to say there are groups who are prohibited or for whom these injections should not be prescribed at all, who would those groups be?
For both is the same. We don't give these medications to pregnant women for weight loss or slimming. Patients with a family or personal history of thyroid cancer, and for children, we can't give them the same drug for weight loss either. But then, between brackets, Sally, there are precautions. So we've mentioned the absolute contraindications where it's impossible to use it, but there are precautions so the patient is also aware. Some patients have an increased incidence of gallbladder inflammation or gallbladder diseases, whether it's inflammation or stones. For patients who take Mounjaro and Ozempic, some patients are exposed to bouts of pancreatitis. And this makes us, when we're selecting the patient to whom we'll give these medications, we inform them that if you've previously had gallbladder inflammation or pancreatitis, we're hesitant to give you the drug. It's not one of the absolute contraindications, to be fair, but we're more worried about them than others. So we tell them if there's another option. Generally, with all patients, we start with diet and we start with exercise. But some people can't just rely on those, or they don't have the willpower, or they've tried and couldn't, or they have osteoarthritis in their knee or hip joints, or they have problems with their spine, so they can't exercise. So we're forced to include the drugs as an option, but we're more worried about these patients. That's why I stress between brackets that people with a history of pancreatitis or gallbladder issues, or a previous history of either of the two. And sometimes we're even more cautious and tell some of these patients that if this condition is common in their family, we prefer to start with something else. However, if we find ourselves in a situation where we have absolutely no other viable or reasonable option available to us besides this particular family of drugs, we do try them as a last resort. Of course, with precautions, with slower, gradual doses, and we educate the patient on the complications and the signs that might appear so they can come back to us quickly and not wait for their follow-up appointment, and so on. That's regarding the contraindications and precautions.
Okay. So some people have the problem of emotional eating or chronic binge eating. Does this type of medication help them stop this constant open appetite?
This type does help them, but we can't start treatment when the patient has a problem that must be addressed first. I mean, those who have this binge eating disorder, it's a disease that is treated. A psychiatrist treats it and prescribes medication for it.
Oh, so it actually has a psychological treatment separate from...
Exactly, that is correct.
People might not know that this is considered a psychological disorder that is treated before we start looking at its symptoms on the body.
Absolutely, because otherwise we'd just be spinning our wheels. Meaning, whatever the drug does, the patient will just undo it. They'll keep paying money for nothing and taking an active ingredient that could expose them to complications. Therefore, we treat these kinds of problems first. I mean, let me add something else to that. If I go back to the previous point, for patients who have, for example, high fats and cholesterol, we worry that very high triglycerides can cause complications for the pancreas. So we tell the patient, let's get the fats under control first before we start the treatment. So there are some issues that we must address before starting the treatment. Yes. And that brings us to a very important point, that there are certain tests that any patient with obesity must have done before starting any medication. This is so I can know if the obesity itself has a treatable cause, or if there's no issue with the patient's endocrine glands, or if the tests have revealed any complications that I need to work on before starting the medication.
So we come to the point of what are the required tests? The essential ones that we can't, skip, that we must do before we start taking these types of treatments.
Okay, great. Let me start with this. Every patient has their own specific case. We tailor or customize the tests we want based on the condition and medical history of each patient. However, if I were to list the basic or primary tests,
the essential ones,
these would include a complete blood count, the patient's blood sugar, we do a fasting blood sugar, and a cumulative one, fats, and cholesterol. Some of the liver function tests, not all of them, so people don't have to pay too much for them because there are many. So we request certain liver function tests. We request one of the kidney function tests and a thyroid test. And if the patient has something else that makes us suspect a problem somewhere in their body, or has a symptom that makes us suspect another issue, we add the relevant test for it. I mean, those are the basics. If we find that those are all clear, we can begin with our medication plan, in addition, of course, to the patient's medical history, in case there's anything that would prevent the use of the medication.
Okay, so what are the biggest misconceptions or things that are, illogical that people have about Mounjaro? I mean, it's obviously not magic.
Exactly.
So what are some of the strange things you hear about it and its treatment?
Exactly. Not all patients, but most patients expect, because these medications are expensive, that I'll reach the weight I want and then I'll stop the treatment. So I save up for the cost of 3 months, or I create an austerity plan to gather the money for Mounjaro, which is frankly very expensive.
Yes, of course.
So I make an austerity plan to get the money for the 3 months. That's what the patient has in mind. They come to the clinic and say, I want to reach my target weight or lose the weight I'm supposed to lose in 3 months.
And you guys figure it out. You figure it out.
That's a nearly impossible task. When these medications were released in research studies for the treatment of obesity, they never said it would be stopped. Obesity is classified as a chronic disease, just like diabetes and high blood pressure. So the goal of the medication is to control the obesity over the long term. So if I help you lose weight in 3 months or 6 months or a year or two, and we stop the medication, you'll gain it all back. Unless, of course, you make a 180-degree shift in your lifestyle. In some people...
And that usually doesn't happen.
It usually doesn't happen. A very small percentage of people are able to do that. I mean, I can tell you, over the past few years, some people have taken Mounjaro, Ozempic, and other alternatives on the market, and then they stopped them once they reached, a suitable weight for them, or once we got them down to the weight they were supposed to lose. Only a small portion of patients managed to maintain the progress they've made. That's the group that was able to make a good shift in their lifestyle. Because the issue, it's a rebound effect, meaning if we stop the medication, you'll gain the weight back. Your metabolism isn't regulated, your eating habits, you don't exercise or you don't have any physical activity.
And you just eat normally?
Yes, exactly. So this is perhaps the biggest thing patients imagine. I'll take it for 3 months and stop. I'll take it for 6 months and stop. None of the studies said it should be stopped. But we are forced to, again, as I was saying, every patient has their own specific case. We are forced to with some people who can't continue to afford it.
Now, this is a very important question. Let's say I've been on Mounjaro, I reached a certain point, I was very frugal, did everything, and got through the few months and reached my target weight. Is it possible for me to continue to do the maintenance, as they call it, or stabilization with Ozempic? Can I switch? Or is that considered a luxury?
No, it's not a luxury at all. We actually have protocols for how to shift between the two. So shifting is acceptable. In the end, both are from the same drug family, which we call GLP-1. So the shift is allowed. And we do it often because there are patients who really can't continue with the cost of Mounjaro. So we switch them to something less expensive. And the opposite is also true. We have patients who start on Ozempic and we don't see a good response.
So you switch to the higher one?
We switch to the higher one. So shifting between the two is allowed and we have a method for it. And by the way, this applies to the whole family of drugs because there are other products on the market besides Mounjaro and Ozempic. We're stressing again that this video is not promoting any of these products.
Exactly. Absolutely. Of course.
So with these products, it's possible for us to shift from one to another. So that's a possibility.
I mean, I followed the plan, I reached my goal, so I can switch to the less expensive one to maintain what I've achieved. Okay, that's very important.
Yes, we can do that.
Okay, let's talk about a very important topic, which is the dosages, how to start them, and whether it's possible to skip doses and so on, if you could explain in detail.
Okay, good. The dosages for Mounjaro start from 2.5. We take the dose as an injection every week for a month. And if the patient doesn't have any severe complications or moderate to severe side effects, we move up to the next step on the ladder every month. So every month we go up by 2.5 until we reach 15 or the highest dose we were able to reach without causing major complications. Almost everyone who starts these medications experiences some side effects related to the digestive system. The patient might feel like vomiting or actually vomits, or sometimes the patient feels a bit faint or dizzy. Sometimes they have a feeling of nausea without necessarily vomiting. At times it's diarrhea, and at other times constipation. I mean, the digestive system gets a bit messed up.
It gets messed up. So these are the normal, acceptable things. The known side effects.
Exactly. However, for a very small percentage of patients, we worry about low blood sugar. Why is that? Because we said at the beginning that this was originally a diabetes medication, or it still is a diabetes medication.
Exactly.
So we advise the patient on certain precautions so they are not at risk of low blood sugar. We also inform them of the symptoms of low blood sugar. So if they experience them, they can take action if they are conscious, or those around them can take action if they are not.
Okay.
Regarding dose escalation, we don't necessarily have to reach 15. Sometimes with a patient at a dose of, say, 7.5 or 10, we can't increase the dose. Every time we try to increase it, they get into severe complications that don't subside. We try to manage them with medication, with lifestyle changes, but they don't go away.
Like what exactly? Like what, doctor?
I mean, some patients get low blood sugar. Every time we go up to a certain dose, they get low blood sugar.
Okay.
We try to adjust their eating habits, have frequent meals, and ensure the patient is well hydrated, but still
nothing.
We go back to the previous dose, and when we try to go up again to the dose that caused the low blood sugar, it causes it again. So that's one example. Other patients have digestive system issues. The patient keeps vomiting, and anti-nausea medication helps a bit. Of course, when a patient experiences severe side effects, we take them a step back. We put them back on the previous dose. Once they stabilize, we then try again to go up to the next dose. Some patients just can't tolerate it. So that's regarding Mounjaro.
Okay, I want to ask a question. Sorry to interrupt you. So we gradually increase the dose. For what reason? I mean, it keeps increasing. Is it to give more room for weight loss, or does the body get used to it? I mean, what does this increase lead to? What are we trying to reach?
Good question. The goal of the increase is to burn more sugar, to burn more of the patient's calories. Ultimately, the weight is, stored as two things, sugar and fat. So when a patient exercises or wants to burn calories or, increase their metabolism, they burn sugar and they burn fat. So the medication burns sugar, and the body, when the stored sugar isn't there or is low, it starts to rely on fat.
It goes for the fat.
And so we actually lose weight this way. So when we increase the dose, we increase the burn rate. Sometimes when we keep a patient on a small fixed dose, they might lose, say, the first 2 or 3 kilos, and then they hit a plateau, or, they stay on a flat line and don't lose any more.
Doesn't lose more, yes.
Yes, and that's why the studies on dose titration were done, so that we don't hit that plateau. When do we accept the plateau? We accept that plateau if I've reached the target I want. I mean, we accept that the patient has stopped losing weight when I've already or have reached the weight loss I wanted. For example, the patient lost the 20% I wanted them to lose. They reached it. I'm okay with that now. I don't need to make them lose anymore. So we accept the plateau at that point. But if I haven't reached my target yet, no. We have to modify the dose or adjust the dose to regulate the metabolism a bit more, to lose a bit more weight. But we also have a limit and a ceiling for the dose.
Sorry, again, because questions come to mind as you're talking. Now, we started with 2.5. Supposedly, everyone starts at 2.5. Some people's rate of weight loss is faster than others. So is it possible, for example, that someone takes 2.5 for 2 weeks, finds they're not losing weight, and then just jumps to a slightly higher dose? Or no, that's not allowed, and I have to stick to taking the full month's dose before moving to the next one? I mean, when I find myself eating normally, not losing weight, and not responding, what should I do?
That's forbidden. What you just said is completely forbidden. It's forbidden for me to skip a step in the middle, because then I'd be more susceptible to acute hypoglycemia. And hypoglycemia, I want to tell you, is not a simple thing. It's one of the most dangerous medical problems for any patient in the world. Because acute hypoglycemia can lead to a patient experiencing organ failure, or it can lead to a coma, or in some cases, God forbid, death. 7.5 all at once is completely forbidden. We actually get patients who do what you just described.
Well, that's why, yes.
Yes, they tell me, I'm going to pay a large sum just to start from this lowest step. No, I want to start with something in the middle. Why don't you start me on 7.5? Of course not. Of course not, because we still don't know how your body will respond. We don't know if the side effects you'll get will be severe, moderate, or if there won't be any. So no, we don't skip any steps. Whether my body tolerates the active ingredient or it's not giving me side effects, or I've achieved a good rate of weight loss on a low concentration and I say, okay, let me just jump an extra step on my own and skip a step in the middle or a rung in the middle, absolutely forbidden.
So it has to be 2.54 times, 54 times, 7.54 times. No one should, get clever and skip something or skip 2 times and then take a higher dose on the third.
And what's more, Sally, sometimes it's not just 4 times. Sometimes for a patient who has some complications that haven't improved yet, we
stay on it for a while.
Stay on the dose that we usually increase every month for 2 months or for a month and a half until, as long as the patient still has side effects, I can't move up to the next step. I wait a bit.
And is it the same for Ozempic? I mean, the same steps and requirements?
Ozempic's concentrations are different.
Okay.
Yes, I mean, its active ingredient comes in different concentrations. The international protocols that set the dosage for Ozempic or the semaglutide within it start with 1/4, then 1/2, then 1, then 1.7, and then 2.4. But the problem we face is that Ozempic doesn't have the 1.7 and 2.4 concentrations. Those concentrations are available in another medication called Wegovy. Why? Because Ozempic, the brand itself, hadn't received the approval. The one that did get the approval was Wegovy. They both have the same active ingredient. So some people use Ozempic in what we call an off-label use. People use it even though it hasn't been approved for this purpose because it's the same active ingredient. It's exactly like this, Sally. Say we have Panadol and Abimol. Both of them contain paracetamol. One company got the approval and the other one hasn't yet. So people use both of them interchangeably because it's the same active ingredient. And that active ingredient is listed in international protocols with a specific dosage. So for people who use Ozempic, their dosage has to be adjusted to match the concentrations available in the Ozempic pens. Why? Because Ozempic doesn't have a pen with a 1.7 concentration, nor does it have one with a 2.4 concentration. So we create a tailored plan for each patient to give them a dose of semaglutide that won't harm them. And we still go up step by step.